everybody to this, the second of our webinars on the VIGOUR project. And today we're going to be focusing on the transferable elements that came from the project. Lutz will go into more detail in terms of the project and how we're structuring it, taking it forward, etc., etc. But really what we want to do is to help to amplify that sort of the learning and the experiences that came from the VIGOUR project and the benefits that the different VIGOUR partners got from the project in looking at their integrated care models and how they were able to twin with other pilot regions within the project to look at some of the barriers and the inhibitors that were being experienced, but importantly, how those were being addressed. And then the learning from that, how they were able to take that back into their own integrated care pilots to address some of the barriers and the inhibitors that they were actually experiencing. So today's webinar will very much sort of pick up on that there, and it will be looking at the transferable elements coming from that. And we have the experiences from colleagues at Graz in Austria, Piedmont in Italy, from Poland as well, and from Valencia, that they will share their experiences with us in it. The format for the day will include an open discussion as well following the presentations, and we are delighted to be able to welcome Ivan Chorbev from North Macedonia, who will join us today and will share his experiences in North Macedonia, but equally important, whether there are any of the transferable elements coming up within the project that he would see could be of benefit to himself and colleagues in North Macedonia as they take forward their own integrated care models. So at this stage, Lutz, I'm going to pass across to yourself to say a few words.
Yes, thanks a lot, John, for this good introduction of the event today. Before we actually straight jump into the experiences made by some of our VIGOUR regions, I would like to provide the attendees with a very brief overview what the overall project VIGOUR is about and what we try to achieve. So as we know from earlier experience and also from the literature, I mean, integrated care is anything else but an let's say all or nothing concept. So in reality, a better joining up of care delivery processes around patients' need can be achieved in principle by very different types of integration activities. As you can see here on this little schema on the screen, for instance, a very straightforward, let's say, way to better, let's say, join up different parties around the needs of a person's receiving care or in need of care can be simple information sharing. Just sharing information about the patient's needs between different, let's say, care providers, different units, even without having a jointly agreed care path available in itself, can already help the individual parties involved to make better decisions about the care that is actually required. So this is, if you so want, the kind of basic step you can take towards better joining up care. Involving different actors, different parties. The next stage would be, let's say, to coordinate actually the care process, for instance, by means of jointly agreed protocols, jointly agreed care pathways. But this level of coordination typically requires also a higher level of coordination in terms of processes, in terms of staff, in terms of rules, in terms of capacity building, and very often also in terms of, let's say, support infrastructure, digital infrastructure, information sharing about, let's say, what care intervention have happened at what stage and so forth. And then there are also fully integrated care schemes, for instance, disease-related. And here in such cases, it's very often even required to, let's say, set up entirely new units or entirely new organizations, possibly by joint funding and so forth. So as you can see here, there is, as I mentioned in the beginning, not an all or nothing approach, but there are different approaches. The VIGOUR project was actually designed to support the 15 regions who take part in VIGOUR to take the next step on their very specific journey towards integrated care. So it was not intended at the to, let's say, implement one or two models of integrated care across all regions. Rather, each region started from a certain, let's say, level it had already reached and tried to take the next step of integration. And depending on the very different, let's say, framework conditions and priorities that had been pursued even before the project, as an outcome, then the VIGOUR regions, let's say, have taken very different strategies towards care integration. And at a very high level, you can summarize the different strategies perhaps under 4 different headings. So one group of VIGOUR regions, for instance, try to better coordinate care with help of multidisciplinary care teams for different, let's say, patient groups in relation to different, let's say, organizational models and so forth. But the key point was really, the key focus point was really a multidisciplinary care team. Another group of VIGOUR regions focused more on better coordinating care around remote patient management. And very often these regions had already some sort of digital care platform in place. And now the question was, how can we better align the care processes involving different parties around this technological solution? A third group focus pretty much on better linking healthcare and social care provided in the community. Very often social care is not provided as part of the healthcare system. And the same goes with the fourth group of regions, which focused more on linking healthcare providers, for instance, hospitals, with preventative well-being services that are available in the community very often, or sometimes even provided by voluntary groups, for instance, exercise groups and these kind of things. So overall, as you can see, we have quite different, let's say, approaches towards integrated care, cutting across different stages of integration, but also cutting across different, let's say, thematic and strategic foci of integrated care. So, but all the regions, despite their diversity, followed the same process and stage process from ambition focusing over then maturity assessment and then taking a concrete operational implementation plan. So that's the general background, what we did in VIGOUR as a project as a whole. And what I would now like to do is I would like to hand over to the first of the pilot sites of VIGOUR, who's going to, let's say, present the experience made while going through this process in terms of a kind of a storytelling approach. So the idea was that we, let's say, rather try to follow the story the pilot sites have reached, and then enable, let's say, questions and discussions based on this. So I hand over to Sonja Wright from Graz. Are you going to continue?
Hello, Lutz. Yeah, I will present on behalf of Graz.
Mm-hmm.
Okay, thank you, and hello, everybody. It is my great pleasure to present to you our twinning experiences of our pilot region in Styria. First, I would like to briefly describe our pilot approach. So our pilot targets elderly and frail people with complex care needs that are residing in 3 nursing homes across Styria. You can see this in the figure. regarding the care delivery process, the in-house nurses at the nursing homes are the professionals responsible for the residents' care at the front line. Additional care, especially with regards to nutrition, is provided by dietitians that come from the local affiliated hospitals to the nursing homes, and medical care is provided by local GPs. We have a well-established ICT infrastructure that supports this whole nutritional care process. The aims of our pilot were to facilitate an integrated and personalized nutritional care for the nursing home residents by making use of pre-existing regional capacities. So we took what was already on the ground and was available and tried to make the process itself more efficient. The interventions we implemented were first the development and implementation of an e-learning module and the conduct of interprofessional team meetings to facilitate capacity building and education and training modalities. And based on that, we finally developed an interprofessional nutritional care pathway for all the professionals that are involved in the nutritional care in the long-term care setting. Okay, next slide, please. Within the pilot planning process, we identified some roadblocks or bottlenecks that you can read here. So at first we discovered very fragmented care processes, not only among the different health and social care professionals, such as the nurses, the dietitians, and the GPs, but also across the 3 locations. This led to very inconsistent procedures in the nutritional management. We also experienced that the target population is very heterogeneous and consists, of course, mostly of older, frail people that have very complex care needs and really need or does need a really individualized care approach. As most pilot regions, we also discovered, of course, that there's a lack of human resources of the whole care staff. There also was a weak communication culture and lack of interdisciplinary communication, and no structured training of the staff in terms of nutritional management was in place in the nursing homes. So we tried to overcome these barriers with our pilot. As a refresher, I listed here the topics of the webinar series where we participated, and these VIGOUR twinning experiences helped us to address also these bottlenecks. So within the first webinar series, we got good insights into the interaction of the training initiatives and the utilization of the ICT infrastructure, and both applies to our pilot approach. Moreover, we got insights into different models of the management of frail older patients within multi-professional teams. So we got insights of experiences of other pilots that target similar patients. We experienced how to create bridges across different care settings, as our pilot also is on an interface between long-term care, primary care, and the acute care setting. And we also got experiences about the development or utilization of specific diagnostic and care pathways, such as were presented by the region of Piemonte. In the second webinar series, we discovered that it is, or the importance of a structured discharge management in terms of care transitions. This is particularly important to us because about 10 to 15% of the residents we target with our pilots, they require transitional care. So and a good discharge pack to the community or to the home setting of the residents and patients is very important. We also got good insights into regional health management models, such as provided by the region of Andalusia. And in the last webinar series, we discussed about the importance of linkage as a mechanism to foster integrated care, and the importance of the practical implementation of vertical and horizontal integration efforts. All in all, it was very informative for us to get insights how other regions use and implement models for integrated care. And although every VIGOUR pilot is unique, to identify common elements and similar approaches helped us to successfully carry out our own care integration process. In our case, the importance of training and implementation of training initiatives for more efficient nutritional care was confirmed and also reinforced by the twinning experiences, and it helped us to overcome many of the bottlenecks we identified, especially the fragmented care processes and inconsistent procedures I presented before. And finally, I would like to provide you a short future perspective about the scaling up of our pilot. So we applied an incremental growth model, which means our pilot implementation process was on a step-by-step basis, and all the activities and interventions we developed and implemented are intended to be lived beyond the project duration. So, for example, the e-learning module is implemented in the existing training platform to enable long-term accessibility. There also are some discussions right now about continuation of this module that provides even more in-depth knowledge, because the interest into this module is very high. All the best practices, the experiences, and the processes that arise during the interprofessional team meetings we conducted will now sustainably be transformed into everyday routine by means of interprofessional collaborative practice. And the interprofessional care pathway is also now going to be implemented into everyday routine. And here the implementation in the practice routine will demonstrate if there are some adaptations necessary. We had our regional final project meeting last week with all the project stakeholders, also from the nursing homes, and they told us that they are now into this step of transforming all the inputs they got during the VIGOUR pilot into the everyday routine, and things are getting better and better by each day. So we are on a really good journey, so to say. I would also like to mention that all these activities are going to be aligned with the national quality standard for nutrition in long-term care that we developed for our National Ministry of Health, that provides some sort of framework or standard guideline for scaling up all the VIGOUR experiences. Okay, I think that's it from my side. Yeah, thank you very much.
Thank you very much, Sonia, on your presentation as well. And you highlighted the importance that when you are developing the integrated care models, that whole importance of the interprofessional working within it. And you highlighted the different training and development needs that were identified and how they're being addressed, not just for now, but also for the future. And I just sort of wonder within all of that, there's another dimension when we think of interprofessional working, and that is the cultural differences or the cultural barriers that might exist between the different professional teams. Did you identify any cultural barriers or differences between the interprofessional teams? And if so, how did you go about addressing those?
We did not really identify any cultural barriers, but rather system barriers between the hospital setting and the long-term care setting. And this was a bit surprising to us because the nursing homes are run by the hospital trust. but the nurses told us that there were some system barriers within the hospital trust. So there are some differences between working processes at the hospital and at the nursing home that make the process a bit more difficult. And we could not yet address this barrier within the VIGOUR pilot, but this was an evaluation outcome for us. And this would need to be addressed within the further scaling up activities, because I think if the system barrier is being overcome, the care integration process would be a bit easier.
Yeah, no, I can understand that, Sonia, and again, it's that linkages across the different services that's important to the whole process as well, to ensure that the systems are streamlined and that they have full functionality where they are. So it's helpful that you've actually highlighted that as an issue going forward as well, and something that needs to be considered when we are looking at scaling up integrated care models. Is that linkage, or is that system integration, and does it actually help to support it? Thank you very much, Sonia, for your presentation.
Thank you.
I'd like to remind colleagues that if you have any questions, if you please post them into the chat box. We will have a session later on where we can come back to the different questions in the chat box and hopefully answer some of those questions or provide the clarification that you may need from any of the presentations. We'll move on now to the second presentation from colleagues at Piemonte and in Italy. Valeria, will you be presenting? I'm not too sure whether the presentation is on this deck or whether you may have to share your screen for it. Or is it Fabrizio? Are you presenting?
Yes, I have to present, but I need to be allowed to share the screen.
I am giving you the hand
Gabrielle?
now. Yes, I am giving you the hand now, Fabrizio.
Oh, okay.
Thank you.
That's fine.
Thank you.
Okay. My presentation is about the pilot of the Vercelli province project, and it is the background is that for any public health intervention, it is for its nature of proactive. It requires a preliminary healthcare assessment. Sorry, I will try just to okay, because I can't. Okay, that's fine. And this is why the public health cycle requires that the beginning of the intervention, in fact, is a needs assessment, and after the needs assessment, we have to identify the main risk factors. And the most important evidence-based intervention to contrast these risk factors, and then implement, evaluate, and the cycle begin for another cycle. This intervention, in fact, is an intervention based especially on the needs assessment. And this starts in the context of the reaction of another European project, that is REACTION, that make a context analysis of the population served by the community health care of Santià, Casa della Salute of Santià. And this was the objective of this context analysis, was to map the characteristic of the population, of the characteristic of the area, of the services, and of the all kind of available things that could help the integration of care. And based on this first context analysis, in the context of the VIGOUR project, what we do is preliminary an analysis of the organization of work, in order to map social and health professionals that could interact in a network. And this is the background of the intervention. In this background, what we also do is the stratification of the Vercelli population in order to identify the different group of population with different risks in order to define which kind of intervention could contrast the risks. And in fact, the population was stratified in 5 groups, and the groups that are especially interested by this pilot were the group of high risk and moderate risk that represent the 47% of the population, people with any level of frailty, from the low level to high level of frailty, excluding people with high complexity, because these people are usually institutionalized and are not interested for us. Another result of the context analysis is the fact that in the population of Vercelli, of the Vercelli province, 35 population over 65, 34.5% of the population is composed by a mononucleus family. There are people who living alone, and what we think, yes, people living alone. And in the rationale of our intervention, people over 65 living alone have an extra risk of social and health problems. And for this reason, we decided that it was important to detect this risk and to develop intervention in order to reduce this risk. And for this reason, in the context of the VIGOUR pilot, we developed a new needs analysis tool that was specifically targeted to people over 65 living alone. This tool is a tool that have the aim to try to identify health needs, social needs, psychological needs, in order to have a complete knowledge about the needs of the population, and to be able to coordinate the intervention in order to answer these needs. The objective was to develop a proactive prevention action in order to lower the risk of hospitalization, the risk of institutionalization, and to increase well-being. The risk of institutionalization is especially important because what we want to avoid is the institutionalization in a structure in order to promote living at home, because the living at home for people over 65 is the best way to maintain good levels of health, of social network, etc., etc. Now we try to explain and to enter to the most important part of my presentation, because if we take into consideration the population of over 65 in the Santiago community, that is 4,454 people, we can estimate the number of people living alone, because it was applying the context analysis that have been conducted at the level of the province. We can estimate that more or less 1,500 people live alone in the community of Santiago. And we can also estimate independently that the population with some frailty, that is the 47% of the population, is more or less 200 people. So the intersection between those that are living alone and those that are have some level of frailty are the target population of our intervention. This is what we found, because we found, in fact, since the intervention was completely based on the family nurses, we found that people in charge of family nurses are 152 persons, and among these persons, people over 65 living alone are 21, and we were able to include in the survey 14 people. These 14 people was a very, very interesting group of persons that give us a lot of information. But there is another point of view that I think it's important to take into consideration. And this, I will try to explain myself. This is the Santia population, the population over 65 in the community of Santia. These are the group of people living alone. These are the group of people with frailty. And the intersection is quite bigger. It is not easy to identify and to count, but is probably hundreds of persons. In fact, we worked on a small sample of this population, 152 persons in charge of the family nurses, and the number of people that we took included in our survey was 14. So I think that this is the main criticism of our intervention, because if you try to take into consideration the public health point of view, we have to look at the coverage. And in fact, the coverage of the population with this kind of the target population is probably very, very low. And this raises a problem of equity, because if we are able to offer to a small part of the population a very important intervention, we are completely forgetting the others, and this is a problem of equity. Given these problems, probably we have also to take into consideration the problem of cost benefits, the balance, the cost benefit balance of these of the intervention, and the global impact, the public health impact of the intervention. So in this intervention, we developed a very interesting tool for the need analysis of a specific part of the population, but the problem is that we were not able to use this tool targeting the whole the population that need to be targeted. Let me now conclude trying to think about which are the bottlenecks that we found. The first one is probably a problem of organization, because in Italy, but I think that is not a problem of Italy, only of Italy, is that the whole health organization is reaction-oriented instead of proaction-oriented. So usually the health system in Italy is used to give an answer to a need and not to measure a need, as what we are trying to do. And in particular, general practitioners tried to shift the responsibility of complex people to the family nurses, because these 152 persons are were transferred from GPs to family nurses. There is probably a problem of commitment, a probably low commitment from the governance board of the local health unit on proactive actions, because they are used to think about only reaction actions. The third one is the limit of data accessibility to the privacy legislation. Due to the privacy legislation, there are still many ambiguities in the possibility to use administrative health personal data to undertake health prevention. It was very difficult to us to try to contact people on the base of our of the knowledge that we have through administrative data in order to involve them in the pilot. And the last one is the lack of a specific data management tool, the lack of a platform for digitalization of the data that is absolutely essential for the organization of personalized proactive actions. So these are our presentation, but it's important to underline that this project have a lot of strengths. The most important is that in this pilot, many different professionals in an intersectional action was involved for the integration of care, and this especially family nurses, psychologists, general practitioners, social workers, and epidemiologists. And this is probably the main strength and the hope that this intervention could be scaled up once the bottlenecks could be resolved. Okay, thank you very much.
Thank you very much, Fabrizio. Interesting presentation on the importance of stratification to identify those patients or citizens at high risk, and then developing the multidisciplinary teams around that to address all of that. In terms of the model that you had taken forward then within Piedmont, what would be the one key message you would say to any region that was considering adopting the approach that you have actually taken to their own region? Is there one key message you would give them that they need to think about whenever they will be adopting that?
Yes, I think that the most important message is that we should put together a couple of different ways to identify needs. The first one is through administrative data, and to identify big groups that are probably carrier of health and social needs. And then within this group, it is important to use specific tools in order to identify personal individual needs, and with the perspective of elaborating personalized intervention to solve the individual needs of these people. And this can be only developed with an integration of people working in the health and social field, because everybody has a part of the knowledge about the way to detect the needs and to solve the needs. So this is very, in my mind, it's the most important message out of our pilot.
Thank you very much, Fabrizio. And we will now move to our third presentation, which will be from Poland. Agnieszka, I take it you will be giving this presentation. Quick reminder to everybody, if you have any questions, please post them in the chat box, and we will come to them later on. Agnieszka, I'll give the floor to you.
Hello. Do you hear me? Can you hear me?
Yes, we hear you. We hear you.
Ah, great. Greetings from rainy Poland. Thank you very much for organizing today's webinar and for the opportunity to share our insight. As a geriatric clinic, we always underline that the most effective treatment for frailty syndrome is prevention and maintenance of intrinsic capacity. Few months ago, we tell you a little bit more about this idea of intrinsic capacity, but I think it's something really really important, and we should remember about it always when we think about elderly people and their health stages. we can do this effective treatment and prevention through a detailed diagnosis in the hospital and treatment prevention and monitoring at home. That's why in the Polish pilot project we create a bridge between medical care and care in the home, in the patient environment. Until now, we haven't a tool to create to coordinate care, and that's why we decided to do it during the VIGOUR project. Next slide, please. The hospital is responsible for the diagnosis. We conduct a comprehensive geriatric assessment by the multidisciplinary team. And of course, we did the rest of elements I presented here, while it is only in the home environment that the key patient care takes place. The implementation of our recommendations depends on patient and on his environment. Next slide, please. To complement and facilitate the transfer of information from the hospital world, we designed an application. Gabriel, please click one more time. Oh, thank you. No. I would like to show you how the application looks like. We try to keep the design connected with VIGOUR, but we use the Polish name W on the beginning, what means the same as VIGOUR in English. This application is friendly to senior patients, and as we observe every day while developing this project, has a higher potential, even more than we initially assumed. You can download this application for free from the Play Store, and right now we add a lot of additional activities, possibilities, and we have version 1.5, and it's still not the end of the basic version. Next slide, please. Do we need VIGOUR to create such a bridge between medical staff and social care? Next slide, please. The answer is yes, of course, and there are a few dimensions which we completely change or improve due to the twinning program, exchange experience, and the series of webinars. Firstly, the target population. We absolutely agree with suggestion that it is a must to include all people from patient surroundings. This is a clue for success. Without it, it's impossible to create integrated care. So during the pilot, we add much more stakeholders than we at the beginning thought. And right now we know that we use different languages than social care workers, and we need to transfer our knowledge, but we use much more understandable and friendly language. Secondly, well-designed IT tool are an excellent support for the management access by all members of care chain in the model. There's an idea to combine our application with the Polish national IKP platform, and we start the discussion, but it needs more. It's not as easy as we thought at the beginning, but we keep discuss about it. Next. Thirdly, creating the link between social and medical care. In Poland, we still have, unfortunately, 2 different ministries. So technically, it is really difficult, but we are able to communicate through the patient. So the patient is this element of connection. Of the connection who can share this information. We still strive to create a legal provisions of technical solutions to develop access for social care workers, and we have seen that it is organized in our countries, and it is really working. So it looks for us that we really are able to do it also in Poland. Fourthly, we planned the education of application users, also to explain then why it is worth sharing the information contained in the application with all people connected with the care pathways. Additionally, we plan to collect data from different periods, creating the summarizes, and we also include a diary of everyday measurements that the patients takes at home. It was also a suggestion from another partner. And next slide. Among the benefits, we realized how important it is to save time, especially when there is a shortage of hands to work. And of course, our assumption should be verified, and therefore we are planning to conduct a clinical trial of effectiveness. And gratitude to partner who really show us how to do it. And finally, education for all members of the care chain is important, and what our partners have taught us can be very effectively done online. And we try to do it even with whole families and patients. That it was really useful. And next slide. For our team, the VIGOUR project was not the end, but only the beginning of our journey through coordinated care. We would like to thank all of you for your support and sharing good practices. We still have many unknowns, but we can now ask the right questions, and I think it's a great step. Our pilot project will definitely be continued, and as you see on the slide, we have some further explanation. So, as I mentioned before, we planned a clinical trial which show how use of the application in the model of integrated care of variety patients can help them to maintain the intrinsic capacity. But also, we would like to support our application to make it greater, better, and more useful. So thank you very much for your attention.
Thank you very much, Agnieszka. And again, a different dimension in terms of looking at your project and moving forward within it. And I thought it was really good at the end to actually see, hear you say that you see all of this as a continuous process, because that's what scaling up is, and taking the lessons that we actually learn and applying in the situation and improving what we do, and then in scaling that up. So it's good to see that it's not all going to stop at the end of the project, but you still have plans for the future. Just one question, Agnieszka, which I'm interested in, and it's because of the integration of digital tools into your integrated care pathway. What were the key lessons you actually learned in the process from introducing the digital tools into the integrated care pathway?
I think that this what was surprise for me, that both patients and formal and informal caregivers, they look for information, and I thought that when we give a patient when he left our ward all the documentation, the medical documentation, it will be useful for them. But during the project, we find out that it is completely ununderstandable. So we have to change completely our language. And right now we start to use completely different language in this application, and also in communication with patients, the caregivers, and also social care workers. It was something really, really important that we are able to cooperate.
Yeah, and that is important, where the digital tools are being used, that the users of those tools actually know how to use them, but also importantly that they have the information in a way and a manner it's easy for them to understand as well. And I think that's maybe something that we all need to think about whenever we're introducing the digital technologies going forward as well. Thank you very much, Agnieszka. We now come to our last presentation from Valencia in Spain, Antonio Cano. Antonio, I presume all your technical problems from the start have been resolved and that you're able to present, yes?
Yes, John, thank you. I am using my mobile finally. I managed to download the program for GoToMeeting, and I'm using it for my presentation. Okay. Gabriel, if you are, please, could you move the slides? Okay. So this is a little bit the scenario in which we have been moving in the latter years in the course of the VIGOUR project. We wanted to implement areas that are related with the promotion of women's health. For that, we concentrated on frailty, also on osteoporosis, and then we even proceeded to diabetic women and women who were survivors of cancer. So our initial idea was to implement a wide use of lifestyle, implementation of lifestyle, including basically in our case in the practice of physical exercise. This was something that we were convinced after managing the many women that were referred to us from the primary care centers, and in which we were recommending different treatments, but our feeling was that most of them might benefit quite a lot from the general practice of physical activity, because any of the treatments that we were recommending, the problem we had was always the same, was adherence. Adherence is very poor if you are considering preventive treatment for any of the main pathologies which are specific for women. And as I say, those pathologies or those threats to health, to healthy aging, were those that were or had a particular feature that made them very specific of women, as it is the case, for example, of osteoporosis. So this was our overarching concept, and from then we initiated a program of integrated care in which it was a vertical integrated care in which we were working with primary care, in which GPs were a key element, but even more, it was nurses. And in our case, we are very much connected with midwives, which in Spain are not only dedicated to obstetric problems, but also to the promotion of women's health in general. So this was, as I say, the scenario in which we wanted to get the most of the program of integrated care. And the bottlenecks and the roadblocks that we have found is something that I will just comment. If you may please move to the next slide. Yeah. This is just to illustrate how important the case of frailty is for women. This is two pieces of information. On the left, this is a study in the Netherlands in which there was a huge population of almost 70 people who were assessed for frailty. And I don't know if you are able to see in the middle of the vertical axis on the left, in which there is a difference between men and women. And you see that women, the prevalence of frailty is higher in women than in men. And on the right, you have the evolution of a cohort of almost 3,000 people, all elderly people in Canada, in which you see also there is a difference between women and men. In this case, the tool that was used for assessing frailty was the accumulation of pathology, the Rockwood instrument for assessing frailty. And you see that as years go on, there is a difference against the women who are in which frailty is much more prevalent than for men. If we may move to the next slide, please. Okay, so this is what we decide at a certain moment. We started, as I said, initially a program in which we tried to implement the practice of physical activity in all women managed by those primary care centers. In our case, it was actually 2 different primary care centers in the health department covered by our hospital. But the problem we found was that the resources we had were very short, and we couldn't address such a program for a whole population of elderly women or women who were at least in the midlife until the end of the life expectancy. So we then decided 2 main steps. One was the use of ICT technology, and for that we relied on the use of mobile phones that were used to connect groups of women following the program in the primary care centers. At a certain moment, we had to delegate the leadership of each group to their own women because, as I said, we only had 1 nurse per primary care center, so the resources were very limited. And so we had to use ICT to implement the program to a wider and wider layer of population. And the other problem we had was that because of this limitation of our resources, we had to focus the program into, I was commenting earlier. So this is actually a seminar that we organized in 2020 to introduce the program for women surviving cancer. And that's when we decided, as I said, to focus our program, our intervention into those most selected groups of women who were more in need of such a program because they were in a poorer state of health. So if we may move please to the next slide. Well, this is just our hospital, and also below you have the 2 primary care centers which are out of the town, and the program that it was a vertical integration, as I said, because it was the connection between the hospital and the primary care centers and the own patients, because, as I said, they at a certain moment took the leadership of the completion of the program and integration of the program of physical activity. So it was a vertical, but also I include an horizontal aspect of our integrated care, because we use, this is something that we have been using the 2 latter years, expert patients to extend the program to other primary care centers, something which has been quite useful and relatively successful in the course of the VIGOUR project. Next slide, please. Well, this is just to illustrate the program in which you see one of our nurses. But as I said, this is only limited to the first group, and then women are instructed to arrange themselves, to organize themselves, to follow the program, and to arrange a schedule to participate in the long term and integrate in the physical activity in their daily life. Next slide, please. Okay, well, this is something I have already commented. So we decided to displace the responsibility of the promotion and the adherence to the program to the own actors, to the patients. And for that, so what we promoted was empowerment with the help of the ICT technology, basically the mobile, which I haven't mentioned, but was used just to keep them connected through basic social networks. Usually they are very fond of WhatsApp, but that's not the only one, but that's the most popular. Go to the next slide, please. Yeah. Also, when we face the inclusion of more specific areas of interest, as like for example the one I mentioned of cancer survivors, what we found was very helpful was the use of the electronic health records. This is something which is easy to manage and easy to make to increase the participation of primary care, because they are connected with us, so they may access to the clinical history, so they may follow easily together with us in the follow-up of these women who are very much involved in the program of physical activity. The next one. Well, this is what I mentioned, that at a certain moment, and because of that horizontal integration, we extended the program to more primary care centers already in town, in Valencia, not in those villages, as I mentioned earlier, and which has been the way in which we have been able to increase the target population which is receiving our program. Next slide, please. Well, we also were using, this is also to illustrate that together with the mobile phone, we tried to use also a website that we use for the transmission of messages and transmission also of education to women. This is something that another problem we found at a certain moment is that it was very infrequent that those ladies that we were stimulating to use the ICT technology, they were not used at all. They didn't have, many of them didn't have even a mobile phone. So what we did for that was to ask for the help of an NGO, several voluntarios, who were teaching these ladies and to introducing these ladies into ICT technology. That was a very good experience, also very limited, because the problem we all found again was the limitation of resources, and those that NGO only was able to help us with a limited number of women. But it was something significant, something that has made possible for many women the access to the mobile and also to this website that we organized, and which was designed to transmit messages and information and formation, also illustration, and to women who otherwise were not, didn't have anything to facilitate the connection with us. On the next slide. Well, this is again to illustrate how we were performing studies with through questionnaires and through telephone calls to these women, asking for how they were managing with this system, which we also were terming as telecare. Which in a way it was, so this is something that you will probably will not be able to read what it is presented in the slide, but basically it's questionnaires in which we were exploring areas like satisfaction, for example, or if they were happy with how the program was being performed, or if they were using easily the system. This is a study actually that we want to publish, and in which we selected 2 different populations at a different moment of the pandemic, a period in which we were very heavily suffering the pandemic because it was very prevalent and with a high rate of disease in our population, and then a more benign period in which the pandemic was low. And we were just also checking and looking for how the pandemic might be fostering the use of ICT technology, because the difficulties for communication were very obvious. And I think there is another one. Slide, please. But yeah, this is another area. We were exploring different dimensions, as I said, and this is all illustrated in that study we have run. And another one, please. Slide. Yeah, that's the last slide, which in a way is a summary of what we have found, which have been, as I say, the bottlenecks, the difficulties that we have found. Well, just to go through the slide, what we have achieved is a consolidated program based upon the use of ICT, which is working in those areas that we have been working with the 2 primary care centers and the 2 new ones which have been added in the course of the VIGOUR project. We have found that new technology may offer additional advantages, still unexplored, because we are convinced that this is something that will give more benefit in future. We've got a database of different data from these women, and which we hope will be very useful in future. The extension of the horizontal axis of integrated care will face opposition in the new affected layers of health professionals. This is one very important bottleneck that we have found, is that health professionals are not really very much committed with these programs, because they have been educated for treating disease, and this is a real bottleneck, an important bottleneck. Well, again, the empowerment of end users is something that is not well received by some health professionals because of the reason I was commenting earlier. And then finally, also the adherence to health lifestyle, which has improved with the use of ICT technology, but still is something that is difficult to maintain in the long run. So even with ICT, there is a limitation that should be addressed in future. And that's, again, one difficulty of our program. I think that's all from me now. I think this is my last slide. Thank you.
Thank you very much, Antonio. Okay. And a very, very quick question before we go into the roundtable. What lessons have you learned from the project that you would actually take and use to address that potential opposition from professionals in the future, where you would look to extend the service or what you're doing into other areas?
Yeah, I think, well, probably the first lesson is in the limitation derived from the lack of commitment of health professionals. I think this is something quite universal, but obviously in our case it's very clear because all our resources are designed to treat disease, but not to prevent disease. And this is something which needs to be changed, and from my point of view will take still some time to overcome.
Mm-hmm. Yeah, okay, thank you very much, Antonio. I'm going to pass to Lutz now. Lutz?
Yes, thank you, John. Yeah. Okay, thanks a lot for these, let's say, interesting insights we have gained from some of the VIGOUR pilot sites. And before opening up the floor to questions through the chat and so forth, I would like to very much welcome again Professor Ivan Kobrev from University Kyrill and Methodios in Skopje. So he is Dean of the Faculty of Computer Science and Engineering, but he's also a member of the Board of Directors in the Business Accelerator, UKIM, representing the university's share. And over the recent years, Professor Kobrev has led numerous high-profile projects and collaborations with companies, public institutions, but also governments, civic organizations, in the field of both science and research on the one hand, but also in the field of innovation and entrepreneurship. So welcome again, a warm welcome. And as we have you here, I would like to take the opportunity to ask you a few questions against the background of your specific expertise, but also against the background of the, let's say, situation of the healthcare system, social care system existing in your country. I mean, what we have heard today are examples of, let's say, approaches taken from quite different angles on how to support, let's say, multidisciplinary care of older people. So, so the pilot site have addressed this from very different angles, and they have also used, let's say, digital technologies in different ways to do this. So, for instance, in Graz, you know, an e-learning tool was developed to focus on the let's say, importance of nutritional care. In Piemonte, a tool has been developed for risk stratification to, let's say, identify risks for people who would require perhaps multidisciplinary care sooner or later. And in Lodz, technology was also used to translate, let's say, information, patient-related information from hospitals into the home care setting, where, let's say, the stakeholders obviously use quite different languages around the patients. And finally, we have seen an approach in Valencia facilitating preventative, let's say, physical activities of people who had received care, female cancer providers, for survivors, for instance, by means of rather, I would say, mainstream technology, mobile phones, a website, so no specific angle. So against all the background of all this, so generally a question from my side, in your country and in your system, are there similar approaches to, let's say, address the needs of older people from a more multidisciplinary point of view?
First of all, hello. Thank you for having me. Thank you for inviting me at this webinar. It's my pleasure. Let me start from somewhere. So my name is Ivan. My last name is Chorbev, Ivan Chorbev. I come from North Macedonia. Macedonia is a small country with less than 2 million inhabitants. It is landlocked in the Balkan Peninsula. I have to apologize for the setting here. I came to a small vacation on the Adriatic coast of Albania yesterday. So now I'm participating from a beach bar. So Sorry for any background noise or anything. My background is in computer science and engineering. I finished my studies in electrical engineering, particularly in computer science and engineering some 20 years ago. And in the meantime, I've completed my master's and PhD studies in computer science and engineering. In the meantime, 7 years ago, I was elected Dean of the Faculty for Computer Science and Engineering. And I've been at that post for the past 7 years. My second term is about to end, and that will be it. My research in the past 8-9 years has also touched along the lines of assistive technologies. My PhD was on e-medicine and telemedicine. And after that, I participated in cost actions and some projects that were focused on assistive technologies. So we have theoretically worked on several projects and devices and software applications that can be used and are used in the self-monitoring, home monitoring, support of the elderly, support of people in need. But little of that is actually translated into practice. North Macedonia is a small country, not very rich. We joined NATO a couple of years ago, and we haven't even started negotiations to join the EU because of a Bulgarian blockade that has been going on in the past couple of years. So not being part of the EU on the Balkan Peninsula doesn't make for a great economy, and to have multi-faceted support for elderly people in need, you need funding. Regarding the medical system, I can start with this. In 2013, the country implemented a national integrated healthcare system, which is an integrated information system to take care of all the medical information of all the patients in the country. So this includes regular diagnosis with primary practitioners, e-referrals for medicines, but also appointments to specialists. And this data set has been growing. The system has been expanding in functionalities and features, but the data set hasn't been so far used in excessive data science analysis. Regarding integrated care for the elderly, I can give you an example of a personal example of my mother and her experience this winter. So my mother has been a patient on chemodialysis for over a year now. She lives in a provincial town on the southwest border of Macedonia towards Albania called Ohrid, which is a nice lake resort. And there are two options for chemodialysis over there. One is nearer to Ohrid, which is like 5 kilometers away, but a better and a more experienced center is 15 kilometers away. So she has to pay by herself a taxi fare to go to the chemodialysis center, which sets her back some 10-15 euros per trip, and she has to do the trip 3 times a week. So this February, my mother fell down walking throughout the city. She broke the pubic bone and the elbow on the side where they have to find the vein 3 times a week. And because I was advised for her to stay at the chemodialysis hospital, but it was full of coronavirus patients, so it was advised to me that she stays at home and only travels for the chemodialysis and not stay at the hospital because she might get coronavirus and that might not end well for elderly patient of 74 years of age with chemodialysis. So things got really complicated because a person with a broken pubic bone has to be transferred 15 kilometers away 3 times a week. I asked around in the capital, Skopje, the chemodialysis patients get a free taxi ride, but not in Ohrid. It's a provincial town and there are no funds for that. So the taxi drivers that now needed to help her with the wheelchair and everything had to be paid extra for the effort. So the 10-15 euro trip was raised to a 20 euro trip 3 times a week. And also we had to personally find a person to help her through the Red Cross. It cost us 200 euros for a month of 4 hours per day help with showering and getting clothes on and off. So all these external support needs to be self-financed and needs to be self-organized and self-coordinated. So there is no particular center that can help me with this. I live in the capital, 180 kilometers away. So I had to travel back and forth several times and spend a week or 2. Luckily, we do most of the work online nowadays with distance learning and online studies and online exams. So I could spend a couple of weeks there getting things organized. But as you can notice from this example, most of the help and support elderly people get is self-financed and it's organized by their children if there are any. And due to increase in immigration towards Western Europe to do work and business by young educated people from Macedonia, many of the elderly are left by themselves to be helped by relatives or other people that are paid by the elderly themselves or paid by their children, earning more money in more developed countries. So luckily, after a month, my mother was surprisingly able to walk by herself. So we stopped the 4-hour-a-day visit by a nurse. She could dress herself up, go to the taxi by herself and do everything. She even prepared some cakes for Easter for me, which is really surprising given the fact that she had a pubic bone fracture and an elbow fracture. But as you can see, we had to organize the transport ourselves. We had to organize the first week or so, 2 weeks after the injury, she had a highly increased level of dead dimers in the blood, which brought a risk for thrombosis. So we did have a home visit by the emergency, by the ambulance. So I had to go to the ambulance and ask for a 2 times a day visit for a nurse to inject my mother with blood thinners, some Clexan and stuff like that, so that we prevent thrombosis. So this was provided by the state, but I needed special prescriptions from the hemodialysis center so that the ambulance comes in the morning and in the evening and give her these blood thinners. So that was free, more or less. And all these complications are, even for my mother is a retired doctor. She was a dermatovenerologist. So even for a retired physician, there's no special care by former colleagues or anything. You have to find your taxi drivers. You have to ask for prescriptions for home visit by the ambulance to get your shots. You have to organize more or less everything yourself. So I cannot speak for any organized, centralized support for the elderly. I had to take care of most of the things myself and my sister. The healthcare system in general is public mostly, but there are private hospitals as well. private hospitals charge a lot for better care. Also, there are private health insurance schemes where you can pay more to a private health insurance fund to get care in the private hospitals if you can't afford that. For instance, most of my students who work in IT industry, because it's a high-paying industry that fights over every single programmer, they generally get those kinds of benefits in the IT industry. They get paid additionally to the salary. They get health insurance, a private health insurance that covers care in the private hospitals. For the rest of us, we get public health insurance and we get public health care, which can be okay. I broke my radius 3 weeks ago, and I went to the public hospital. I got an X-ray. I got a cast. It was okay. You can get surgeries. You can get everything, but it's better if you know people. In the private hospital, you get better care. So this is a short introduction. I don't know how much time I get, or if this was what you expected to hear. So theoretically, in my work with my team at the university, we've done all sorts of fall detection sensors, artificial intelligence monitoring, home monitoring, cameras, sensors in the beds, sleep detection, facial detection, all kinds of theoretical, scientific, IT, home monitoring experiments and studies and papers published and projects successful, but only a small fraction of that, if any, reflects into the real life of my countrymen.
Yeah, thanks a lot, in particular for these, how should I say, real life picture that you gave. I mean, that triggers some thought in relation to what we have heard earlier. I mean, would you say it's fair to say that in the end of the day, any solution of integrated care of the elderly, let it be strongly ICT supported or with, I think, mainstream ICT, when it comes to uptake, pretty much depends on, let's say, the real world circumstances, the structure, and not at least the generosity of the healthcare system in terms of staff available, in terms of institutions available, in terms of money available. I mean, if that's the case, so from what I take, especially in countries where the main burden still rests on the shoulders of the family and relatives and so forth. In particular, the approaches we have heard about that rely on very, how should I say, straightforward mainstream solutions like telephone and so forth, trying to involve expert patients to instruct others. Do you think that would be something you could imagine that could find its way into reality in your country?
Well,
so apart from the highly scientific research-based monitoring, let's say, technology, more the, let's say, low-end technology to strengthen the capacity of the environment, of the family, of the informal carers.
So in North Macedonia, the crucial aspects are provided for free by the government. The actual chemodialysis my mother gets is free and it's high quality. I mean, the machines are top level and everything is fine, but small stuff like getting there and other things are not provided. What they started offering nowadays, I read somewhere an advertisement on that, is a home button that makes a phone call to the emergency unit for the elderly to quickly, urgently get support if they fall or lose consciousness or they feel very bad. So they provided them with some really simple, probably phone that dials a special number that gets emergency support, just a single button. So that's a novelty. I read somewhere it's coordinated between the Red Cross and the health, the emergency response teams in the hospital. I can't give you details on the support provided in special places where, how do you call them, homes for the, so in retirement communities. I can't give you details on that because I don't have experience with retirement communities. There are several of them for elderly that have no family to take care of them, or have no room for that, or the care is too complicated. So the kind of level and support they get over there, I cannot give you details because I've never visited one. I've had friends and relatives that have brought people to live there in retirement communities. They do get support and care by nurses and doctors. I know of several examples, but I can't give you details on the technology used there because I've never visited one. But generally, I think in Macedonia, we've developed a prototype example of cloud-based smart home and health support system. It can easily be implemented because in Macedonia, there is broadband connectivity everywhere. So every home can get a fiber optic link to the internet, and people usually live in urban areas, either in apartment buildings or in houses. So rarely do people live in remote villages or away from civilization. So it's rather simple to install smart home equipment or home monitoring equipment in urban areas where most of the people live, in apartment buildings, so they can get home monitoring equipment that is inexpensive, and but that needs the initial installment of such equipment. It is not even expensive. You can use off-the-shelf Arduinos and Raspberry Pis and stuff like that. But the actual maintenance and response to the alarms that these equipment would generate is a problem, because you need staff to visit the person after you get an alarm. You need because electricity can stop, internet can stop, so you need to update, monitor, maintain the equipment. So installing the equipment might be easy, but actual usage and maintenance and support can get complicated in time. So yeah, things can be done, things are available. We've done prototype examples. We've worked with the university in Linz and in Vienna to make a puff-puff mouse for quadriplegic people to use computers and move around in wheelchairs. They even flew some drones with the puff-puff mouse. Linz. So we've done collaboration with centers with expertise, but we haven't put in practice many of the things with theoretically.
Okay.
Not in Macedonia.
Okay, thank you very much for your insight in the situation in your country. We have already overrun, and especially many thanks that you spend the time with us despite you're on vacation. So I hope
it was a pleasure.
I hope you will relax. Nevertheless, you will have your well-deserved holidays. So I hand over to my colleague Francesca to see whether we have some questions from the chat still. Thanks a lot. And also apologies for not correctly pronouncing your name.
No problem. I don't expect anyone to be. CH stands for Ch, like Chorbe.
But okay.
I don't expect for people to come on. Don't worry.
Thank you. So, Francesca.
Thank you, Ruth. Sorry, we have overcome the time, the scheduled time, so I will try to be quick. There is a question actually in the chat from Maddalena. I guess was addressed to Sonia, but correct me if I'm wrong. Care transition.
Basically, it's a more general question because the first speakers referred several times to the need, to the relevance of integration of services between hospital and community. So I was wondering whether there is an agreement among VIGOUR participants that we could identify probably a sort of services, first the services supporting home monitoring in the first period of following discharge as the linkage services. Because this could be something useful to have a clear vision of what is the linkage services referred to. This is also a question to Lutz, because several times we have had difficulties in visualizing an example of a service that could correspond to one of the 3 different layers of integration. So from the general conversation, first of all, it is important to connect the hospital with the community services. Second, it is important to manage care transitions. So it could be possible that we identify as an example of linkage services, protected discharge. First, I don't know how to call it at this moment, but it could be a couple of examples. I don't know if this was for Sonia and also Piemonte, because the colleague, I think he left, so I'm not sure it's still connected.
Hi, Maddalena. Yeah, if I understood your question or your suggestion correctly, I would agree, of course, that we refer this to the linkage of services. What comes to my mind immediately, we talked about, or we in Graz talked about, this was in one of the webinars, about a nutritional documentation tool. Just to give you an example, we have here at our hospital that is dedicated for patients that are transferred between settings, so to enable a good information flow between the hospital and the community settings for patients in terms of nutritional care, for example.
Yeah,
I think
this is an example of how you can link a specific type of services, filling the gap between hospital and community. And then you can identify the next step, that is the takeover, full takeover from the hospital of the community services, because it may take some time and some further sharing of knowledge from the hospital experts towards the community. Because in the hospital, as you mentioned, we have a lot of different experts involved, and this brings a higher value to the services, high complexity services, more specific services. So maybe this.
Maybe Maddalena, to add from my side to this. So I mean, Sonia, I mean, you have been mentioning the let's say linkage between hospital to other care settings, elderly homes and so forth. But to me, the example provided by the colleagues from Lodge, I mean, they point to another aspect when it comes to linkage. I mean, if we understand linkage as information sharing between different units involved in care without necessarily agreeing a joint care plan or joint protocols, I mean, then what comes to the fore from the example in Lodge is that it's not sufficient to let's say enable the transition of information from one unit to another in Lodge from the hospital ward to the home care teams, whoever will form the home care team. But it's also important to think of whether the information can be understood.
Yeah.
So these app they have developed translating the information that is available in the hospital according to certain, let's say, clinical categories, clinical language, and so forth, into information that can immediately be used by the home care teams, by the family, the social care team, which is not at all used to, let's say, use these clinical terminology, is a very important, let's say, aspect that is often, let's say, forgotten when we talk about linkage. So
Yes.
linkage is not just to establish information channels, but also to make sure that the information can really be understood and exchanged, I mean, content-wise. So that's an important aspect.
Univocal interpretation, because otherwise it becomes complicated. So there is another level of adaptation we need to consider, that is in the communication towards specific targets, even in the execution. So this is important. We should highlight that there is a need to adaptation where in the linkage towards the community to also work on the way to transform the information. I don't know how this can be done, because sometimes it's qualitative information. So I don't know. It's often it is qualitative information, and yeah. So a couple of more things. If I jump straight into the highlights emerging, there was a focus on the value of sharing the good practices and experiences during the interprofessional training meetings. And this was emerging in all of the presentations, because this facilitates the transformation and integration of these experiences into the practice. This makes the integration of activity and services more effective. So this is important, and it was highlighted by all the people who presented. And another point is the low awareness of policymakers and the decision management level of the need to valorize the proactive approach to service provision and in the prevention activities. This was highlighted also by Antonio, and this is important when you scale up, because if you don't have decision makers willing to invest more money, it's impossible to broaden the number of people taking advantage of the services, and we implement something that is not equitable, because only a little group of people can access. This is something that was also highlighted by Piemonte. So there is a legacy of the legislation on privacy that we also heard from Emilia-Romagna, that they could not implement large scales of risk stratification tools because of GDPR issues. And a very important point was also made, another point was also referred, the reference to the cyber volunteer by Antonio. This is something that could be taken up as a suggestion to inspire new skills and new jobs, especially if we could manage to combine digital literacy with health literacy, because the two can go hand in hand and give a more added value to the new tools. And last, another observation by Antonio, the integration of self-reported data with databases. This is an opportunity, provided that we manage to address the issues related to quality of the referred data. But with the availability, of monitoring tools and self-reporting that is automatically carried out by tools, this quality issue could be overcome. So I think there are very interesting inputs that can be highlighted.
Thank you, Maddalena. I see there's a comment, but maybe you already mentioned it. So we are out of schedule. With just a few words from our side to about some points that emerged from the Friday's webinar and today's webinar, and also by the work we have done, as promised, by collecting the templates, documenting the pilot implementation. And is that the pilot has shown that the effectiveness of integrated care approaches depends especially on a context-sensitive implementation strategy and carefully tailored digital support infrastructure. And also that the pilots demonstrated that the importance of close integration of clinical, public health, and other services if the needs of patients are to be met, we'll say, to a reasonable extent. So this from just a few points from my side. And if there are no any other questions, I will close the webinar, and I would like to thank you for all of you for the fruitful discussion.
Okay, thank you.
Thank you very much.
Thank you.
And
Thank you, everybody. Bye-bye. Have a nice afternoon.
Thank you. Bye.
Bye-bye.
Bye.
Thank you very much.
Thank you. Have a nice day. Bye-bye.
Thank you.